My name is Shengren Xu. I'm an attending physician at the Division of Endocrinology and Metabolism at Changhua Christian Hospital in Taiwan. And for this session, I will discuss with you about diabetes care in older adults, pregnant women, and youths. According to the estimates of the International Diabetes Federation, currently 1 in 11 adults 20 to 79 years of age have diabetes, which amounts to 463 million people in the world. In particular, the proportion is much higher among the older population, with 1 in 5 people over the age of 65 years afflicted with diabetes. Also, there are currently over 1 million diabetic children and adolescents in the world, most of whom have type 1 diabetes. Additionally, there is a very great proportion of pregnancy, about 1 in 6 live births, that is complicated by hyperglycemia. And so this topic will focus on diabetes care among the old, the young, and the pregnant patients. First, we will discuss the care of older adults with diabetes. According to the recommendations of the American Diabetes Association, in caring for older patients with diabetes, one should consider assessment of the medical, psychological, functional, and social geriatric domains in order to determine the targets and therapeutic approaches for their management. Especially, the older patients should be screened for geriatric syndromes such as polypharmacy, cognitive impairment, depression, urinary incontinence, falls, and persistent pain, which may affect diabetes cell management and diminish quality of life. Diabetic patients should be screened for cognitive impairment and dementia when they reach 65 years of age and re-evaluated annually as appropriate. Hypoglycemia should be carefully avoided in older adults with diabetes, as they may worsen complications from hypoglycemia than younger patients. Glycemic goals should be individualized for each patient, especially since the elderly have a higher risk of hypoglycemia. The duration of their diabetes is usually longer. They have shorter life expectancy. They may have multiple associated comorbidities and diabetic complications. And depending on their functional capacity, they may be more passive in their own care. And so therefore, a less strict glycemic target with the HbA1c leaning toward 8.5% may be more appropriate for the older adults. Accordingly, we can divide the patients into 3 groups: those who are relatively healthy, those who have complex or intermediate health problems, and those who are in poor health and have very complex health problems. Those who are healthy may have more stringent glycemic goals, including an hemoglobin A1c of less than 7.5%, fasting glucose less than 130 milligrams per deciliter, and bedtime glucose less than 150 milligrams per deciliter. Those who are intermediate may have the A1c goal raised to 8%, fasting glucose up to 150 milligrams per deciliter, and bedtime glucose up to 150 milligrams per deciliter. Whereas for those who are in poor health, an A1c of 8.5%, fasting glucose 180 milligrams per deciliter, and bedtime glucose of 200 milligrams per deciliter should be sufficient targets. As for the choice of pharmacotherapy, particular preference should be given to medication classes with a low risk of hypoglycemia. Overtreatment should be avoided, and for those who are treated with complex regimens, one should try to intensify or simplify the treatment regimen in order to reduce the risk of hypoglycemia and polypharmacy, provided the A1c target can be achieved. For the elderly as well as younger adults, the drug therapy of first choice is metformin if the initial HbA1c is not excessively high and the patient is not symptomatic from hyperglycemia. Metformin is highly effective in lowering blood glucose and yet has little or no hypoglycemic risk. However, one must be aware of the risk of lactic acidosis in patients with organ failure, especially those with impaired renal function. If metformin alone is insufficient or if there is contraindication to its use, then another agent may be added or substituted for metformin. For the elderly, the second agent should preferably have low hypoglycemic risk as well. All of the currently available anti-diabetic drugs except insulin and insulin secretagogues such as sulfonylureas and glutamate have very little or no risk of hypoglycemia. So essentially, any agent beside insulin and insulin secretagogues can be chosen if there are no contraindications. For elderly patients who are on a complex insulin regimen, we may try to simplify and decrease dosages as appropriate to reduce hypoglycemic risk. For example, for patients who are on the basal bolus insulin regimen, we may change the injection time of basal insulin from bedtime to morning and reduce dosage as necessary to keep fasting glucose above 90 milligrams per deciliter. The mealtime insulin may be gradually decreased while an oral agent is added and increased until the mealtime insulin can be discontinued. And for patients who are on a pre-mixed insulin regimen, an attempt can be made to replace it with a once-daily basal insulin, which is simpler to administer. For elderly patients with advanced organ failure, the prevention of hypoglycemia is of even greater significance, but they are also at risk of dehydration from hyperglycemia, which must also be prevented and treated. As oral intake decreases, insulin and agents that may cause hypoglycemia should be reduced in dosage. And as for the patients near the end of life, it may be reasonable to discontinue all diabetic medications as they are unlikely to have any oral intake. But a small amount of basal insulin may be given to patients with type 1 diabetes in order to prevent acute hyperglycemic complications such as ketoacidosis.